Good. So intra-articular problems, we have cartilage and bone problems, alignment and stability, ligamentous stability are additional key points, and we have to have not only cartilage, also the meniscus also has an important role on both sides, medial and lateral. And many times these are young patients, so alternative for us arthroplasty in young patients is really what we are looking for. And I would like to sensitize you for new joint preservation, preserving options like intra-articular osteotomies, osteochondral bending and shaping. Sometimes we have grafts, but the shape of the graft does not fit where we want to place them. So can we modify the shape of grafts? That's a question. And everyone is talking nowadays about 3D printing. And I will share with you that this goes beyond printing fractures or deformity models. These 3D prints can help us as guides, as templates. So we can do 3D print template guided navigation, which is extremely helpful in complex deformity because it allows us to precisely place our cuts. And finally, sometimes we have situations where the deformity is so extensive that the destruction of the cartilage osteochondral situation is so bad that we cannot repair it anymore. We need to somehow replace it and using biological materials, allograft. I have no conflict of interest for a couple of paid editorial tasks that are listed here, or national and international patents. And the problems in orthopedic trauma have been nicely outlined by Ashok Gavaskar just a few minutes ago. We have cartilage damage, we have cartilage defects, we have joint destructions, we have alignment problems, we have ligament problems. And the problems with joint replacement in the young, especially in the young patient, is they have more implant loosening, they have shorter implant survivals, they have more and multiple revisions in a lifetime, and they get more and more complex and more complicated. And when you look in the literature, there's very few written on intra-articular deformities and intra-articular osteotomies. One of the very few papers was just mentioned by Kirchhoff and René Marti some years ago, and even they were intra-articular but extracondylar osteotomy. They moved the entire condyle as a piece, but it showed that we can really improve the patient's situations quite significantly. But the problem is many deformities are even more complex that they can be handled with the intercondylar osteotomies. Let me quickly step into what do we need in imaging. Of course, conventional X-ray and long-standing film. But I would like to focus on the fact that we can do nowadays easily CT scans. And I frequently see that we get images, CT data sets of the ipsilateral fractured and deformed side. But frequently, the healthy contralateral side ends up in the bin of the radiologist. And that's very pity, because the contralateral side gives us an enormous plenty of information, which is very helpful for planning, for judging the shape of the deformed bone, and it helps us to show and to plan where we want to go with our correction. So keep the contralateral side data set, which is in the ring of the CT scan anyhow, keep it for your evaluation and for your judgment. MRI is always said to be very good and helpful for the judgment of the soft tissue, which is cartilage, which is ligaments, and which is a meniscus. But I find it often very difficult to read because sometimes these tibia plateaus and these distal femurs are full of metal. So we have a scattering of signal, and it's very hard to read sometimes if this is a side effect of some metal or some defect of the cartilage. So I like much more the so-called CT arthrography, a combination of intra-articular contrast dye given together with a CT scan. And look at these images, how nicely you can read the bone, how nicely you can judge the cartilage. Even the meniscus can be judged in parts. So I prefer for planning of complex intra-articular deformities, I love the CT arthrography. Instruments, pretty straightforward, very important, the laminar spreader in order to open up osteotomy sites, to clean it out, and to make fragments, intra-articular fragments, movable. I actually would right away start with you with clinical cases. I have prepared 4 cases, and I would like to start with Jacqueline. Jacqueline is 50 years old, and she had a missed lateral tibia plateau impression fracture. That's her plain film. It was missed in the initial hospital, and she had her first X-ray several weeks after trauma when everything was already healed. This is her lateral tibia plateau. You see here there's something impressed, something abnormal, and the CT scan shows it exactly because this is the lateral condyle. We see the joint to the fibula, and usually this is some sort of convex. And when we see it here, this is the superimposed contralateral side, but with the ipsilateral side has this deep defect depending of where you watch it, and you see a deep concave defect impressed by the femoral condyle. And if we go to the AP view and superimpose the contralateral normal CT scan, we see healthy, but here in the ipsilateral side we see significant impression of the lateral parts of the lateral condyle. So this all has healed, but the patient has significant amount of pain, VAS of 7. She is unstable. She walks on crutches, and she presents 9 months after trauma. Everything has healed. So how can we correct an intra-articular deformity, a concave deformity on the lateral plateau? And when I was thinking about solution, I had these 2 things in mind. The one is the toy for children, which makes a rigid stuff, wood, very flexible. And this is something I learned in Asia, that if you cut in a certain way, you can bend and make concave structures to convex and vice versa. So these observations have stimulated my planning for this case, and I was doing experiments with a reciprocating saw, cutting multiple times just underneath the cortex and a little bit inside the cortex, so to make multiple cuts, and the multiple cuts, like in the fish, all of a sudden get flexible, get bendable, so we can go underneath with a destructor and fill it up with bone graft. So this was the theory, this was the idea. Let's have a look how we do in this case. Here's the preoperative situation again, and here the postoperative situation. What we achieved, we were able to make the concave deformity to a convex shape in both planes, AP and lateral, and here the MRI before with the concave defect, which was then nicely elevated. So here the situation, pre and post-op films on the lateral view, nice convex correction in both plane. And we have done an MRI before and after osteochondral bending. Here's the views 1.5 years after this surgery. The bone has nicely healed and the patient has significantly improved. Her VAS scale became much lower and her Lisholm score increased to 81. Not perfect, but significantly improved, especially in terms of pain. So if this works, I would like to share another case with you where osteochondral bending might be an option. And this is Uwe. Uwe is an anesthetist in a neighborhood hospital, and he sustains this lateral split impression fracture of his proximal tibia. Here's a preoperative film. Underestimates the amount of deformity, but when you see the CT scan, you see this significant anterior destruction. So one of my consultants took him to theater and fixed him, and these are the post-operative films, and we see something is behind some metal. And the real information we get again from the CT scan. And what we see is we have a normal structure here, but in the middle of the lateral plateau, there is impression. There is no cartilage situation. So we decided we bring him back to theater, and with something in mind, which always drove me when I'm operating proximal tibia fracture with the posterolateral approach. There you have access to a joint, and you can use the articular surface of this joint for small or medium-sized reconstruction. And we have two types of fibula. We have a concave type of articular surface, and we have a convex type of articular surface, and usually we need convex type of grafts in the lateral plateau. So let's go back to Uwe. See, there's a significant articular defect where there is significant articular deformity, and when we draw a line with the shape of the contralateral side, we see not only the defect in the anterior and middle part, we also see that the posterior part is slightly depressed, and this needs to be addressed with a chisel, and the posterior part needs to be elevated. And the best way to do this is to approach it with posterolateral approach, because you then see the entire lateral condyle in order to judge curvature, etc. Here on the right side, we see now, our first intra-articular view at the revision. Here is posterior. This on the right side is anterior. We have elevated the meniscus, and we see part of the meniscus is trapped into the joint, and this is something which would not promise a good result. So we mobilized it. We mobilized a piece of the articular surface of the proximal tibiofibular joint. It was a convex type, and we have then identified, and multiple cuts from the bone side make this all of a sudden bendable. As you see here, it's concave, but we can flex it. We can make it concave, we can make it convex as we like. We can play with it, but the cartilage always stays intact. So we can replace some of the defect with this graft. And you see here the molded osteochondral fibular graft covers large part of the defect, and all of a sudden this joint again looks like a joint. The hardware was left pretty much in place, just the screws have been newly placed, and that's the post-operative CT scan. in comparison to the preoperative CT scan, we see good elevation of the joint in both planes. We have some, again, some sort of a neutral or semi-convex plateau. And here is the patient 1.5 years, 4 years after surgery. He is a runner. He resumed running again. Very happy patient, no pain, good daily stability, Lissholm score 96 of 100, good Tegner score, and he is back to anesthesia and running sports again, and all covered with this small graft obtained from the proximal tibiofibular joint. Another case, and I would like to share this case with you because it shows very nicely the benefit of 3D prints. This is Mohammed. Mohammed presented first when he was 24-years old, and he has sustained a B-type femoral fractures, which was malreduced in varus in Libya. And he reported a pain level between 6 and 8, and this was also healed. He presents 2 years after trauma. We see here on this photo this varus deformity. We see on his first X-ray a fracture which has been stabilized with these conical screws. We see also some shrapnel, making any MRI very, very difficult. But when we look at the CT scan in combination with intra-articular dye injection, a CT arthrogram, we see very nicely his problem zones. The problem is joint incongruency. We see steps, defects, and interruption of the cartilage. His meniscus was pretty much intact, and also we use 3D analysis of both sides in order to judge the amount of correction we need. So we have superimposed the 3D data sets from the healthy side, and the healthy side is gray and the injured side is green. And so we see very nicely that we have about a shortening of almost 10 millimeters in both plane. And not only that, we also have some additional bumps, intra-articular bumps, which cause additional pain and problem. And this 3D data sets, as you see here, can be nicely used to play on the screen to do virtual osteotomies in order to end up with something which closest fits the contralateral side by comparing the green fractured side together with the gray normal side. So this is very, very helpful. And based on this, we can construct targeting aids made from plastic, which can then be sterilized and used intraoperatively as guides for osteotomy, as guides for reduction, and as guides for implant placement. So I'm quite sure that for my generation, it is enough to do email and Word and PowerPoint, but I really would like to encourage future new generations to play with this software, to learn it, because this will be the basis in the future. The future will be 3D, not 2D anymore, and we need to learn this, and these are instruments for the modern orthopedic surgeon in order to better understand deformity and to better understand and to make better solution for this problem. So we corrected this case in 6 steps. Step number 1, we created the distal master block, and the distal master block perfectly was complementary in shape to the distal malunited fragment. And it is nicely to reference because we just use the holes of the screws which were removed. Then we need a connection block to the proximal master block, and then we have two referenced structures on the bone. And step number 4 is adding a cutting block to the proximal master block, which nicely defines the cutting plane, and we can virtually and in reality then nicely and very precisely cut this bone with not so much soft tissue disruption and not so much uncertainty, which we would have with normal planning and performance. And here we have a reduction block in step number 6. A reduction block has these connectors, and the connectors snap into the proximal master block, and they snap into the distal master block. And once this fits with this reduction block, we know the amount of reduction is done, because it's a deformity in multiple planes. It's shortened, it's rotated, and it's also deformed in valgus and sagittal plane. So here some intraoperative shots after arthrostomy. We see. Sorry. We see the old heel fracture line. We see the bump here, and we do the different steps we just saw. Here is the complementary surface to the deformed condyle, which snugs in very nicely. This is connected with screws to the bone. And then we do similar things on the proximal screw holes, add the osteotomy block. This is before cutting. And then we use the oscillating saw along with the osteotomy, and now we have loosened the malunited fragment, and we can manipulate it, we can shift it, we can rotate it, we can put it more distal, and this is controlled and supported with the reduction block. The reduction block, as we have seen, is snagged into the proximal and distal master. So there is only one position which fits the perfect reductions, and this is additionally controlled with the alignment rod, and then we can go on for fixation. Here, angular stable plate, but still we have to address the local bump, which needs correction. We do a wedge type of osteotomy, here a closed wedge type, and here after removing the wedge, we just bend again the osteochondral fragment, and we press it against the femoral condyle, so we have again removed the bump, and we fix it with the low-cost titanium K-bars in order to minimize the amount of implants. Looks the shape, it looks nice again compared to the preoperative bump here. Additional cartilage with ACT, chondral graft, and this is sutured in. And look at the postoperative imaging. We have now a perfect knee alignment axis, a perfect mechanical axis. We have a good restoration of the shape in the lateral view. The bump is gone. The radius of the distal femur is now restored again. And when we look at this here, we see a nice curvature of the distal femur. Here is a titanium K-bar, and look at the shape, very nicely achieved as a normal radius. Here we have the screw. So the screw worked as a spacer in order to prevent mechanically from closing the gap and which has an additional strengthening effort to the construct. Here's the situation in the CT scan. Again, green is the preoperative trauma side. Gray is the post-operative side of the same side. And look how nice the both surfaces match to each other. Gray and green is comparing preoperative planning and postoperative CT scan, and this shows that it could be nicely been achieved. Here's the situation. Walking the patient down the stairs with pain and instability. At 1 year follow-up, the Lissome score increased from 80 to 100, and knee society score also significantly increased, and pain has significantly decreased. Very, very happy patient. And the final case really shows that we also need sometimes solutions when we have large combined defects, like Irmgard. Irmgard is almost 60 years, and she presents again very long after her initial trauma, horse riding accident with significant pain, VAS up to 8, instability. She is dependent on crutches, has an increasing valgus deformity, as we see here, and a recent arthroscopy and partial implant removal had no effect. And everyone whom she contacted initially told her, you need a total knee replacement in order to solve this problem. But someone gave her my address, and we did a thorough analysis. She not only had a large defect in her lateral plateau, she also had a non-union in her tibia plateau. So I was thinking on osteochondral allograft transplantation, but before you do this, you need to have a real good ground for the transplant. But once you have achieved this, the data from the literature shows that transplant survival is not only short-term, but also long-term, up to 15, 20 years. And if you use a fresh, thin osteochondral allograft, the data seem to be quite okay. But in many trauma situations, we need larger cover. So we developed this Floxat concept, fresh, large osteochondral shell allograft transplants. And this is something I would like to highlight here based on this clinical case. So Irmgard has this large defect, and in step number 1 of the 2-step reconstruction was to build up the defect with a large autograft from the posterior iliac crest and let it go for 6 months to have ingrowth. And we overstuffed it in order to really fill the defect. So we filled this large 4 by 3 by 4 centimeter osteochondral defect and addressed this way also the non-union she had in the posterior aspects of this proximal tibia. And once this was healed in, based on CT scans, we did planning for the osteochondral allograft together with the lateral meniscus, and 3D data analysis supports this very nicely. Here, the intraoperative situation at the transplant day, we had done a posterolateral approach. This is the transplant. This is the graft, which was then trimmed together with the lateral meniscus. So she got a chip, which is fixed with 1 screw and 2 titanium K-bars. This is the border between the graft and the transplant, and there is a lot of inherent stability, so you don't need much more fixation other than the screw and the K-bar. This is her 12 months after trauma, which good increase of her functionality. and look at her, how she is running up and down the staircase. Look at the x-rays before with a large defect and after a transplant, and she had a good and sound ingrowth of her bony part of the transplant. And not only it looks good on radiograph, but also her functionality is good. You can read her on the Knee Society score. We have now 60 months follow-up, which is 5 years. Both very good values, both on Leisholm score and Knee Society score. And really the worst case for a knee is being on a trampoline, especially if you are on a trampoline with other persons. You need a lot of coordination and you need a lot of trust in your knee performance. And we scoped Ingrid 1 year after her allograft transplantations, and look at this arthroscopy video, the indentation test with palpating hook. It's a very nice and soft feeling, which represents almost normal cartilage. The lateral compartment was very nicely. Also, the meniscus had a good stability, and we took out a little biopsy of her cartilage and sent it to the lab in order to check what cells are these. Are these still donor cells, or are these recipient cells which have with a chimerism been replaced over time? And the result was that 32% of her donor cell cartilage cells were exchanged with her own cells. So let me summarize. Intraarticular deformities, post-traumatic intraarticular deformities are complex problems. They are not only related to cartilage, but also to alignment, ligament stability, meniscus are important options. And there are some new ideas for addressing these big problems. For example, using the proximal tibiofibular articular surface and to do some osteochondral bone shaping. There are new options on the horizon with 3D printed templates and template-assisted navigation during osteotomy. And finally, allograft transplantation. It's an old method, but I think there are still good arguments in order to reuse this with modern techniques in order to be able to help our patients with difficult intraarticular problems. Thank you very much for your attention.